अरूप सर, गुड इवनिंग।
गुड इवनिंग, गुड इवनिंग।
सर अपनी स्लाइड प्लीज आप फुल स्क्रीन मोड में कर लीजिए।
फुल स्क्रीन दो वो अच्छा फुल स्क्रीन देते बोले दिस वन। ओके, इज इट ओके?
यस सर, थैंक यू
ओके
सर।
ओके ओके।
Good evening, everyone. I hope all the postgraduate students are joining and will join shortly. We don't want to delay. We don't want to keep the students waiting for the exclusive class by Dr. Professor Arup Kumar Majhi. You all know Sir has an excellent book on obstetrics and gynecology, and Sir is an excellent teacher. We know him for so many years. For all our Gurukul classes, we request him to come and take classes with our Gurukul classes. And every year, twice a year, we call him, and he's always happy to come and join us. For last 2 years, we had virtual Gurukul classes, and he was kind enough to participate in those virtual Gurukul classes as well. So today we have requested Sir to teach you all the basics, that is history taken in obstetrics, and I'm sure you all are waiting to hear from Sir. Sir is a very senior teacher. He's a national president-elect of ISOPAV. At present, he's Professor Shantiniketan Medical College, Bodhpur, Birbhum, West Bengal, and Scientific Committee Co-Chairperson of AICOG 2023, Kolkata. Earlier, he was professor and head RGKar Medical College, Kolkata. He had been President Bengal Obstetrics Society, Vice President ISOPAB, author of Bedside Clinics in Obstetrics and Bedside Clinics in Gynecology, 28 years of teaching experience, and he is examiner of UG, PG, DNB, MCI inspector, DNB accreditor, so many publications, so many books, and he has been past editor of Indian Journal of Perinatology and Reproductive Biology and past national corresponding editor of Jogi. Over to you, sir. We all are waiting to hear from you.
Thank you, Dr. Mala, for your nice word. Probably I have not so much as you have described me, and I am very fond of teaching, and more than 28 years and 30 years I teaches on the undergraduate and postgraduate student. So I will be very happy they are benefited from this basic class of history taking and examination in obstetrics. And in fact, the students' problem when a case is given to the student, most of them, not most, many of them becomes fumble what they will do, how to write the history and how will they present the history. But it is only thing is the practice. Before going to appear any exam, at least 2 history you take and write with you, because the problem one is that the time, 40 minutes usually the time is given for history taking, 40 to 45 minutes, but your target will be finish it within 30 minutes, and you will make the protocol how will you write very easily, and you should not omit the important points, because the examiner will see the some important point. Not all of them are very habituated to see all the points, but you see the very important point. So with this small introduction, I'll going to my actual classes, the history taking and examination of obstetrics, and how will you read the summary, and what should be the provisional diagnosis, and also what investigations you do in a case of obstetric case. Obstetric case means you are given 2 cases. One is the antenatal case and another is the puerperium case. So all the investigations you know. The antenatal case is actually the history taking and examination of the mother also. The puerperium case, many students are very afraid of the puerperium cases, but I am very happy, and you are also very happy to know how to write a history taking of the puerperium. That is very easy, and that will be a history of the mother, history of the baby, examination of the mother, and examination of the baby. But you must see there are little examination in the puerperal mother, and also for you the baby in the exam. There are only 3 examinations. I am not going into the details of the program today. I will confine my presentation today, the antenatal patient. And lastly, if I get time, I will go few points about the program, what we will do. Now, the basic things is that a long case should be written under the following broad headings. All of you know, there maybe you can change also, but this is the basic thing. One is the patient's particular details of the past patient, you will more paragraph you will write, and make the history taking, and second is the physical examination, including the systemic examination. Physical examination, that is the general examination, general physical examination, including the systemic examination. And you must remember, you will have to do also the systemic examination of the obstetric patient. And until you do not do, you will not be able to exclude the important diseases like heart disease, or if there is hepatophilia like that. So you must do the systemic examination also. Everyone will do the only the physical examination. And obstetrical examination, I will go how to do it. I will do that. Includes the breast examination of the breast, and also the inspection, palpation, and auscultation. And investigations supplied. Usually for postgraduate examination, investigations are given and supplied. Particularly the blood examinations reports and the USG examination report. If it is not supplied, you must write the what should you get or what to do that particular obstetric case, particular the patient you have been given, and then make a summary and write the provisional diagnosis in one sentence only, and make the difference. The differential diagnosis is not needed in the obstetrical cases, usually not needed, but particularly few instances like why there is a polyhydramnios, you could write the twin pregnancy, multiple pregnancy, polyhydramnios, like that. And you always, when the examiner ask you what is your case and describe your case, you will try to confine in the summary of the case, so that the examiner gets time to question you summary of the case. But in the summary, the relevant points you must tell. In the relevant points, you must find. I will tell you how to present the summary. What you will confine to the summary, including the sum of the details parameter which is relevant to that to your patient. Now the patient's particular, the name you must write, and this is here the bed number you can write here, bed number, date of admission, and date of examination. You will write on right side, not necessarily in the last. Better in the left side is this one, this 9 points, and right side the 3 points: bed number, date of admission, and date of examination, and age. And you write down first the age, and your examination may be finished with the age. Only the finished. There are so many cases in the age, like the what are the importance of the age of the patient, like in teenage pregnancy, there are some special problem. Teenage pregnancy, the patient, the girl usually suffer from the anemia, and there also she is not prepared to be mother, and so there may be the preterm labor, intrauterine growth restriction, and preeclampsia. The incidence of preeclampsia also in case of the teenage mother. And like teenage mother, the elderly pregnant mother, elderly mother are also there is a risk, particularly the chance of medical disorder, diabetes, chance of hypertension, preeclampsia, and also there are so many problems that are fetal growth restriction and dysfunctional uterine bleeding. Sorry, dysfunctional labor, during the labor. There are so many problems in case of elderly. So these are important, and you maybe ask question: what are the incidences of the teenage pregnancy at present? The National Family Health Survey report has been published, 5, and you will see the about 24 to 25% the pregnancy are the teenage pregnancy, and the younger age, marriage younger age. before reaching the 18 years. And teenage pregnancy, I am sorry, it is now has come down about the 7 to 8%. Teenage pregnancy rate has come down. And next is the address is very important, but many patients cannot say the details. Until you write down whether this is urban or rural, and if better to get how much distance from the hospital. Suppose the 15 kilometer or 20 kilometer, whether she can come immediately. Otherwise, you will have to make admission the patient beforehand in the Addis case. And her occupation is also very important. There is a questions of the maternity leave also when you will give according to the gravity of the cases. Now, duration of the marriage, because not only the history of infertility, but duration of the if a patient becomes conceived after 4 years, 5 years, without any contraceptive, without any using the contraceptive. So she is the subfertile patient. You will have to take special care. And if there is an infertility, what types of medications to what procedure was taken, whether the ART technique or simple medicine, you will have to details take the history. And husband's occupation, particularly it is related with the socioeconomic status, husband's occupation. But socioeconomic status means it is the actually it comprises the income of the patient, income, and also the occupation of the patient, and what are the activities he has to do, and what is the social condition she lives there. And it is usually there are so many methods, but you just like that the my social low, middle, and higher category. You write like assess and like the category, the socio-economic status. And religion, you just write, nothing, no important. And parity and gravida, this question is really asked in the what is parity and what is gravida. All of you know gravida is all pregnancies, irrespective of the periods of gestation, previous pregnancy, and the present pregnancy. And parity means it is only the previous pregnancy cross the viability. That is the now the viability is said it is the 24 weeks of pregnancy, not previous victim it was the 28. So who has crossed the 20, but not this pregnancy, irrespective of the status of the child, whether the living or dead. So this is about the patient's particular you will write. As I have said about the age, according to the National Family Health Survey 5 just published in the May, 23 to 3% of men surveyed got married before attaining the legal age of the 18 years. Legal age of the 18 years. So there are so many complications, maternal complication and child complication, perinatal mortality also increase, infant mortality of the increase, because there may be lactational failure. The baby suffer from the different types of infection like that. And teenage pregnancies has come down from 7.9% to 6.8%. This is very important data just has come in May 2022. And now the history. What history we will take? That is very important. That is very important. Now, first is the chief complaint and complaint. Next is the history of present illness. Next is the menstrual history. Next is the present obstetric history, that is the history of present pregnancy. And past obstetric history of previous pregnancy is very important. Past history is not past obstetric history. It is and the next is the family history. Family history, because family history has an important impact on teen pregnancy. If the parents suffer, woman's parents suffer from the diabetes mellitus, patient may suffer from the diabetes, hypertension, and preeclampsia also. Functional history, there is a bowel, bladder, and appetite. Functional history, personal history, personal hygiene, how she attends, and what food she takes. And medication history, particularly medication means what medicine she takes, and also if there is any allergy of any medication. And you will have to take the anticoagulant drug history, the corticosteroid history. And contraceptive history. Contraceptive history is very important, because regarding the contraceptive history, what happens if the patient conceives just immediately after withdrawal of the contraception. And what may occur, sometimes there may be false amenorrhea, because withdrawal of contraception, medical, particularly the oral contraception like that, there will be some amenorrhea, false amenorrhea. So we will have to in trouble to calculate the exact expected date of delivery. I will tell you, yes, sir. And social history, that is the birth preparedness. Birth preparedness is a new term, but in your exam, in postgraduate exam, theoretical examination, the question may come on the birth preparedness. Birth preparedness, it is related with the patient, it's related with the society, and related with the family. How they will, the mother will prepare herself to appear in the hospital, and also can take care, can be taken care by the hospital and the authority for service provider. That is the birth pain, all aspects. But suppose this in the night there is a labor pain, she will to attend there, and who will give with her? That is very important. All the aspects are the birth preparedness. It's a new things, but now it is given after the WHO and the National Health Mission. And menstrual history is very important. LMP means the first day of the last menstrual, and expected date of delivery, that is the expected date of delivery, and period of amenorrhea, you must calculate period of amenorrhea from the LMP. And first day of the expected date of the expected date of delivery is calculated by expected date of calculated by the Neglis formula, that is by 9 months and 7 days. I think all of you, the 9 months, 7 days, adding the first day of the last menstrual period. But remember, if the cycle is regular in the 28-day cycle, this is correct. If the cycle is lengthened, suppose the 35 days, so 7 days you are adding, you will have to add more in the ADT. And it is 21 days, 7 days you will have to deduct. So that then you will have to do the corrected expected date of delivery. And period of amenorrhea, you better to calculate the days and divided by 7. Calculate the days and divided by 7, and then you period the which is actually the period of amenorrhea. And there is a also you can app. There is some app. Is it not given to use in the exam? You can calculate also the period of amenorrhea. Now, very important is the age of details of the menstruation, the age of menarche, duration of menstruation, interval in days, regularity of the cycle, pain during period, amount of bleeding, and clot. This is the common things in menstruation. And now, calculation of the EDT I have already told. The pregnancy is dated from the LMP, that is last menstrual period, as exact date of conception is not known. Total duration of the pregnancy is considered as the 208. I have heard from the many students, this is the total days of pregnancy, the 37 weeks. It is not like that. It is the 40 weeks, 280 days. But the expected delivery, usually delivery does not occur all the patients on the expected date of delivery. Majority of the patients delivered before and or after, and only very little number of patients are delivered on that particular day. And expected date of delivery calculated by the Negli formula. The expected date of delivery obtained by adding the 9 months, 7 days to date of the first day of the last menstrual period. Negli rule is based on the 28 days regular cycle, and ovulation is assumed to occur on 14th day of the 28-day cycle, ovulation. And you will remember, if the cycle length is longer, but the last 14 days is almost constant. So increase in the, that is when there is no availability of the oocyte and fertilization. Now, there is very important thing is the present obstetric history, the history of the present pregnancy. Before that, I want to again emphasize use that LMP taking of the LMP sometimes become difficult. So many patient will tell there is a particular the festival or like that. So you will also be remembered. You will be prepared yourself. You will be prepared yourself. What is the particular festival of and if it becomes the pregnant, she becomes conceptions occur in the lactational amenorrhea and also in the amenorrhea following contraception, and so you will have to calculate the naturally the question is how will calculate the expected date of delivery. And the single answer is the early pregnancy scan, because the early pregnancy scan is corroborates mostly with the length of the pregnancy. 10 to 13 weeks, the crown term length corroborates, and after 14 after 14 the abdominal circumference. The first your answer will be the first pregnancy scan is the important. Other you will there are so many methods to determine the expected date of delivery. Quickening is not possible, not possible in early months. Physical examination, PV examination is usually not done. Para-abdominal examination and the antenatal, from the antenatal record you can get some idea. But the important answer is the early pregnancy scan. And usually most of the cases this is not done. If it is not done, then you will search for other. Now, present obstetric history, the history of present pregnancy. But if frequently we neglect this case, present obstetric, because you will have to write like this. If you like this in systematic manner, antenatal care, and you event of the first trimester, event of the second trimester, and events in the third trimester. And also what drugs is getting any complications with that, and what are the used finding. You search the antenatal record, antenatal care details. Details means antenatal care, how many antenatal care she has been checked up, and what is the last antenatal care, and when she first came to the antenatal clinic. That is important. And Government of India and WHO recommended that now previously it was the book case in the 4 cases, that is the book case. But now recommended following 2016, and when labor in a pregnant mother should get 8 antenatal checkup. Not always checkup. She will come to the hospital or she will come to the service provider. But it is the service provider, that is the health worker may visit there. That is, it is called the antenatal visit also. The total and first trimester, what is the importance of the date of diagnosis of the pregnancy, history of threatened abortion, is there any excessive vomiting, hyperemesis gravidarum, that may indicate like the H-mole, or also the multiple pregnancy, and without any cause there may be hyperemesis. And whether she is getting the folic acid supplementation from the very beginning and even before that, and history of pyrexia and urinary tract infection, because urinary tract infection sometimes, if it is recurrent urinary tract infection, there is a chance of the preeclampsia, and there is a fetal growth restriction, and there is a preterm labor also, and any drug intake when in the first trimester, that the teratogenic drug. Now, until and unless indicated, no drug should be taken during the first trimester. There are only some proven drug that is not harmful. And any USG scan, that is very important. I have already said, any USG scan in the first trimester, dating scan, that is also called the dating scan. And second trimester, usually there is no some important event. Only thing is the date of quickening, because the quickening occurs in the 16 to 18 weeks of pregnancy, and the mother, the multi-gavita can understand, but primary gavita does not always understand before 20 days. So she can say the 5th or 6th month, but that is important only case of the missing the LMP. And third trimester important. Third trimester is very important, but all the complications occur, majority of the complications occur in the third trimester. And anemia, antepartum hemorrhage, and preeclampsia, and fetal growth restriction, fetal movement, preterm labor, or any fever, and any bleeding TB. Whether there any third trimester complication the patient suffering from. And history of iron and calcium intake, injection tetanus toxoid or injection TD. Now not the tetanus toxoid is given, the Government of India giving the tetanus and diphtheria. And in the private sector, ACOG, particularly American guideline, the Tdap, tetanus, diphtheria, and pertussis single dose after 26 weeks of pregnancy, 26 to 34 weeks, like that. At the Tdap. And in this respect, you may be asked what are the vaccination can be given to the mother vaccination, because It's very important. Vaccination is actually, other than routine tetanus and TD or TDAP, other vaccination is given for special circumstances, but can be given, and some vaccination are totally and contraindicated. Only the dead virus are given, like the, if the patient visit the hepatitis B area, hepatitis A area, like the pneumococcal can be given, meningococcal can given, but chickenpox vaccination cannot, lump some MMR vaccination cannot be given because there is the live vaccine. So you have to remember which vaccination are given, and now the COVID vaccination, irrespective of the period of gestation, usually is recommended, but beware to give in the first trimester, but it can be, there is no such contraindication till now, because the harmful effect of the COVID, all of you know very much, and the benefits are more. So this is about the patient obstetric history. And one important thing is that when a patient, your obstetrics notebook, what you will write, the chief complaint, regarding the chief complaint, you will see the chief complaint, what will you write in the chief complaint. Usually the patient has come with the amenorrhea, but don't only write the she has been admitted for 9 months. You write something for what is the reason she was admitted, like swelling of the legs, like she has been diagnosed with the diabetes, for a hypertension, I would like this. But only on 2 to 3 points you will give in the chief complaint. And if there is no point, only for the examination the patient has been admitted, you can write that the patient has been admitted for the safe vaginal near date, substance for safe delivery. For safe delivery, the patient has been admitted in the, suppose she stays far away. And history of patient illness, that is the patient illness, is you elaborate the chief complaint. And in the history of patient illness, you must the positive points, must the chief complaints. Suppose the bleeding PB, what is the onset, what is the severity, what is the duration of the bleeding PB, you must write there. And also the if it is the hypertension, the preeclampsia, when started the diagnosed fast, and what is the severity, how it is controlled. You have the details of the you write in the history of the PN, and also some negative relevant point. Now, if there is a excessive bleeding by vaginal bleeding, whether it is painless or painful. Painless means antepartum hemorrhage due to the placenta previa or other thing like polyp like that. But if it is the painful, either the abscess placenta or maybe due to the pregnancy. So due to the labor, that she has gone into the labor. So pain during the bleeding, and you will have to, if it is present or not, you will have to write down that. So in your summary, you will write down the negative relevant point, important relevant point, that you will differentiate to reach at your diagnosis. So now present, after present obstetric history, the past obstetric history is very important, past obstetric history. Because from the past obstetric history, you will get many information that will help to prepare for this pregnancy. Suppose that there is a past, there is a severe preeclampsia or eclampsia or diabetes that may recur. Preterm labor, there is a chance of recurrence. Fetal growth excision, chance of recurrence. And there is a fetal death, there is a chance of recurrence. You will have to think they will admit the patient beforehand of the last fetal death. That is our dictum. Now the definition of the parity and gravita. That is the parity I have already said. Gravity I have already said. Px plus y is another way. It is not so popular now. X means the previous viable pregnancy or pregnancies, and Y means previous pregnancy or pregnancies not in the age of viability. X means the previous viability. And another method, that is actually the standard method, that is the mnemonic, the F-Pol, P-F-Pol. I am coming to that. And living issue, and you must find the living issue before past obstetric history. What is the living issue? Suppose this third gravida now, living issue nil. That is the very high bad obstetric case. So living issue one, or male, female, or how many years back. You write down that. Primigravida nil. Primigravida past of cyst nil. Last childbirth. What is the distance of the last childbirth? Because if it becomes the more than 5 years, there is a chance of complications occur. And if it is a successive year, 1 or 2 years, there is a chance of complications also. Now, gravida means a pregnancy state, both present and past, irrespective of the period of gestation. And parity means only previous pregnancies reaching beyond the age of the viability. It includes live births in any gestation or stillbirths after 24. You see the live births in any gestation. Live births in any gestation. You write down that. That is also comes under parity. The mnemonic, that is the F fall, that is the PF fall. F means full term, first digit, and P means second digit, the P term infant. Third, for remember, is the F fall. A means abortion, and L means living children. P4, 1, 3, 2. So it means the woman had 4 term deliveries, 1 preterm delivery, and 3 abortions and 2 children. F fall. It is only to remember how to write. Now, past obstetric list, you write this manner, only this manner. And before that past obstetric list, you write the parity, just before that, in the and gravida, and also the living issue. That is, to write down here, this here, write down here, the parity, gravida, and living issue. And you may write also the very beginning of the patient's particular there. Now, serial number, this is very easy to remember. I am telling you. The serial number 1, 2, 3, 4, all pregnancy you will write. If it is the abortion, you will write. With the twin delivery, you will write. If it is the H small, you will write. If you will ectopic pregnancy, you will write. All things you will write. And the term pregnancy, all things you will write. When she has conceived any, you will write. And year and month, pregnancy events. If it is the pregnancy event, it's the term pregnancy, normally delivery, no complication. If there is a pregnancy events, when the antepartum hemorrhage or preeclampsia or diabetes, any complication you will write. Labor events mean the complicated labor, like that complicated labor, there are prolonged labor, or during the labor there is a severe postpartum hemorrhage or retained placenta is also like that. So there the labor, prolonged pregnancy, prolonged labor or like that, difficult or like that. The patient was in labor, that cesarean section was done, or forceps delivery or delivery. And mode of delivery you will also do. So, and puerperal and postpartum period. Puerperal postpartum 6 weeks, or postpartum uneventful or not. And regarding the baby, we will read whether the baby is living or not, and whether the baby weight at that time, whether the baby is immunized, and at present the baby, how the baby is. That is very important regarding the baby. And birth weight is better to write the birth weight of the if remember. So this is about the past pregnancy, but don't forget to write also the other that is first trimester abortion or like that. Now, risk of pregnancy, you can assist after the history taking the past pregnancy. What is the utility? What is the importance of using the assist by the previous obstetrician? Where unexplained stillbirth may be due to undiagnosed gestational diabetes and cholestasis of pregnancy. That is the stillbirth. There is a very important question is exam. What is the unexplained stillbirth? What is the undiagnosed gestational diabetes? And also cholestasis of pregnancy was not diagnosed. There are some few symptoms. And time of interrupted death, which is considered for planning in pregnancy. It is the dictum. Suppose a patient delivery occur, interrupted fetal death occurs at the 38 weeks of pregnancy, you will admit the patient before that and monitor, and then you will deliver. And mode of delivery, particularly the previous cesarean section, that is the impact. If there is a previous cesarean section, there is a more of placenta previa, there is a more chance of the placenta accreta spectrum, and the hospital, there should be the master hospital delivery. And instrumental vaginal delivery in the previous pregnancy. What are the indication? Instrumental delivery, there is some indication also. There may be some pelvis, there is a problem in the pelvis, or there may be in the power passage passenger. There will be macroscopic, maybe like that. Power means the incoordinate uterine action, and passage, that is there may be problem in the theta, problem in the uh, uh, pelvis also. And history of prolonged labor, difficult labor, and birth of asphyxiated baby, birth trauma, and PPI should be kept in mind during delivery of the current pregnancy. And birth trauma, whether there is a birth trauma. Birth trauma means there is a complete perineal tear, maybe complete, there is the cervical tear. So last pregnancy, if there is a complete perineal tear, there is the whether you will allow for the vaginal delivery or not, and what precaution you will take. Complete, there is a complete oasis, that is now recently known as the oasis. And there is an increased chance of fetal growth restriction with previous delivery with fetal growth restricted baby. And previous birth of the macroscopic baby may be related to the gestational diabetes mellitus, undiagnosed. And there is chance of recurrence if there is a delivery of the congenital abnormal fetus in the previous pregnancy. Now, past history also very important. Past history, not I am going to the past obstetric history. Past medical history and medical history also in this pregnancy. That is very important, because if the patient suffer from the diabetes or hypertension, particular diabetes, hypertension, there is a problem. Diabetes means there is a chance of the preeclampsia. There diabetes means there is a chance of the unexplained fetal death, and the chance of infection is also more. And bronchial asthma, there is you will not, in case of bronchial asthma, you will not give the prostaglandin injectable, prostaglandin, and intravenous. You will give the IM only. If you need due to the prostaglandin, bronchial asthma, and also there is the problem during labor or late pregnancy. There is the bronchial asthma. Thyroid disorder is suffering from. Any patient suffering from the thyroid disorder must be euthyroid before the pregnancy, because thyroid need is needed for the first trimester more, first half of the pregnancy, because the thyroid, fetal thyroid is not completely formed, and deficiency of the fetal thyroid may cause that intelligence, IQ of the patient. And renal disease, heart disease, epilepsy particularly the whether she is taking the anti-epileptic drug or not, and there is a chance of convulsion during the pregnancy, a rheumatic fever, and HIV, thromboembolic disorder, corrective tissue disorder, rickets nowadays is late, and myasthenia gravis, their maternal muscle fatigue, fetal neurological disorder, psychiatric disorder. So these are the medical problems. You must take the history, and you will details. Many are more in my book. You will read the, my book, you will read everything is detailed. So why you will take that? Gynecological history is very important. And I have already about the gynecological surgery, the VBA repair, CPT repair, prolapse repair, also the PCOS pregnancy. And there is a PCOS, if there is a pregnancy following treatment of PCOS, there is a chance of there is a chance of the early pregnancy failure, there is a preterm labor, and future their patient may develop gestational diabetes like that. And also ectopic pregnancy. Ectopic pregnancy means already she has lost her one fallopian tube and PID. And family history is very important. 3 family history is important. One is the diabetes, hypertension, and the multiple pregnancy. And multiple pregnancy, maternal, there is a chance. And hypertension is the parent of the woman. There is apart from the diabetes or hypertension, may present chance of preeclampsia, and also the diabetes. In particularly the first degree relative parent or sibling, more chance of diabetes. Other also important, whether there is a family thromboembolic disorder, history of birth of the baby with congenital anomaly may run, congenital anomaly, or chromosomal disorder, tuberculosis, the patient may be infected in the family. Blood dysphagia, severe psychiatric disorder. If there is a severe psychiatric disorder, there is a peripheral psychosis, so that background is very important. So these are the patient psychiatric disorder and also family psychiatric disorder, because psychiatric disorder may run in the family. So these are about the past history and family history. And social history, I have already said, family member, they are who will support and will care her, availability to bring health facility, her birth preparedness, and her diet at home, diet and nutrition, load of work and type of house she resides, contraceptive history, duration, times, and last use of the contraception. Sometimes the withdrawal of oral contraception may lead to amenorrhea, during which patient may conceive, and LMP may be fallacious. And medication and the drug is what medication she is taking, if there is drug actually, whether she is taking in a corticosteroid, and anticoagulant, and any hypertensive drug, any anti-diabetic drug, or whether is taking like that. Now come to the physical examination, and this is for come to the general physical examination. This is very important because the build you like that you can alter the postgraduate, but these the you must cover all the things. Build, nutrition, height, weight, edema, anemia, cyanosis, jaundice, tongue, teeth, gum, tonsil, neck veins, neck glands, neck veins, pulse, respiration, temperature, blood pressure. You must mention all these things. And systemic examination, cardiovascular system, respiratory system, GI system, examination of the other system. And examination of the other systems, important is the ophthalmoscopic examination. You may get a finding, you may get a report from the ophthalmoscope, particularly from the preeclampsia and severe preeclampsia patient. There is the retinal edema, retinal hemorrhage, and also the change of the arteriovenous ratio, and kinking, when constriction of the retinal arteriole. These are the important findings. And regarding the GI, I am telling these are you will not forget. You will forget GI system. You particularly if there is a patient suffering from anemia and liver disease, you must palpate the liver. And you don't forget to palpate that. This is the common mistake of the student. The liver is not palpated. If your case is anemia, you must exclude whether there is a splenomegaly or not. Thalassemia, hepatosplenomegaly. You must exclude. It is very difficult to palpate, but you must exclude it. Write down it. The liver is palpable. And the cardiovascular, routine cardiovascular examination. Heart sounds is already normal or not different heart sound. Respiratory sound is normal. Now build you write down. It is build maybe average, or is the poor, like that. You like and good. You can write like that. The build is actually the skeletal structure, the short stature from distance, not the measurement. The skeletal structure of that particular individual. And nutritional status of the patient, you can understand whether there is the malnutrition, whether there is a features of the malnutrition, particularly in the tongue, teeth, gum, tonsil, there will be the features of the glossitis or like that. And next is the nutrition. How will you assess the nutrition? And the body fat. It's the skin thickness. You will see the skin thickness. By your hand, by your thumb and index finger, you see the skin thickness. Your skin thickness, you can you see what is the nutritional status. Also the arm circumference, the thigh, upper thigh circumference, the nutritional status. Height you must measure. Suppose there is a no measuring scale is like that. You bring the patient to the near the wall. Bring the patient near the wall and mark the upper mark the head in the wall, and then take with your tape what is the height. And at least you mention that may be slightly different. And weight is important. And height, weight, that is the BMI you must calculate. I am come to the BMI. What is the important to the BMI? And now edema you must see. How will you see? I will show you. And anemia, I will see the anemia is very important. Cyanosis you will see. And jaundice you will also see the jaundice. And tongue, teeth, gum, tonsil, whether there is a history of the gum bleeding, whether it is the gum swelling, or the tonsillitis of the neck veins, neck glands, and leg veins. This is routinely done. And pulse is sometimes there may be difference of the pulse in the right hand and the left hand. So you will try to palpate if there is a cardiovascular disease. All pulses you must palpate. And the respiration, what is the rate of the respiration? and if there is a temperature on a during examination, you can get. And blood pressure is important. Examination is very important. Blood pressure. Height, short stature one, which is the short stature actually. And this will picture you will see in my book. Short stature woman is usually associated with the small pelvis and low birth weight, low birth weight, low birth weight. What is the importance? Small pelvis and low birth weight baby. And that low birth weight baby may be due to the constitutional, and the baby mother is also short stature, or in the due to intrauterine growth restriction or preterm delivery. And there is no consensus of the upper limit, but the recommended is that 140 centimeter height or below is considered as the short stature. 140 centimeter, approximately 4 feet 7 inches. And some group, many population upper limit, where there is the different ethnic variety, is the 145 centimeter, 4 feet 9 inches. So what is the short stature important clinical? It is the upper limit of the short stature, that is the 140 centimeter is a widely accepted. Why 140? And now weight. Weight, the BMI calculation. Weight in kg, assess overweight or thin or underweight. So assess by the BMI. You must calculate the BMI because its question is usually asked to the student. Weight in kg by height in square meter. And the BMI less than 18.5 underweight, 18.5 to 24.9 healthy, 24 to 29.9 overweight. More than 30 or equal to 30 is the obesity and morbid obesity after 35, morbid obesity. And weight should be taken in the first visit. This is very important. Not the day you are examined, the first visit, and immediately before the pregnancy, pre-pregnancy, that is the ideal weight to calculate the BMI. Because the weight of the third trimester is not, the BMI is calculated on that day, but not is actually the BMI that will affect the mother. And there is the risk of the FGR, high perinatal mortality, in case of when there is a less than 20 and more than 20, there is the development of the hypertension, GDM, macrosemia, high perinatal mortality. And during the recent National Family Health Survey 5, which is published just 1 month back, the incidence of overweight obesity among Indian women, not the pregnant women, it is about the 24%. Can you imagine? Every one woman of 4 is the overweight or obese in our. So it is also maybe the epidemic, the obesity. That is very important. The physical exercise, yoga, and nutrition and balanced diet is very, very important. And sedentary habit, that is important factor. Now edema. Edema, how will you see the edema? You will see the edema. All postgraduate, you must see how the edema is seen. I have seen many postgraduate cannot see how to see the edema. Edema you see, just above the medial malleolus, elicited by pressing with the tip of the right thumb at least for 15 seconds. You see, this is the medial malleolus. Some says medial malleolus like here, some says like here, some says is like that. But medial malleolus, above the medial malleolus, elicited by pressing above and medial to the medial malleolus. Right thumb at least for 15 seconds. You can say 30 seconds, but this is the demonstrated how you can see like this. The medial malleolus above, medial malleolus above and medial. That is the way. And edema can also be seen the shin bone also. There are other you can see the hair, you can see the sacrum, and also the abdomen. There may be the edema. The vulval edema is important. Other demonstration of the edema is there. You must be you may be asked about the what are the causes of the edema. Majority of the edema of the physiological, and that is usually relieved by the rest or lying down position. Prolonged lying down position, the edema vanishes. The majority of the, and due to the pressure by the gravitational and changes of the colloidal osmotic pressure. So these are the important other causes of the edema. Edema is not the diagnostic feature of the preeclampsia. But when there is a edema, you must exclude the preeclampsia. In the diagnosis and definition of the preeclampsia, edema is excluded now. Definition is the hypertension and proteinuria or any other systemic manifestation of the preeclampsia. But you must exclude if there is a edema, exclude there is a preeclampsia, because edema is the one cause of the preeclampsia, one manifestation of the preeclampsia. Other causes of the edema are the nephrotic syndrome, hyperproteinemia, or SLE. These are the other causes of the. You can see the pitting edema is like that. Is like that, pitting edema. And other anterior surface of the lower third of the sigmund, dorsum of the foot, over the sacrum, parietes, and over the vulva. But when he is asked to see the edema, you see the near the medial medulla, and vulval edema. You can see the vulval edema, dependent part, vulval edema. Anemia and pallor. That is very good. What is the difference between the anemia and pallor? Pallor is anemia is actually a pathology. That is the less hemoglobin, and pallor is the clinical manifestation. That is the color of the mucous movement, with the skin and the tongue, and also the palm of the. But anemia is actually, it is the medical terminology. Anemia, it is the diagnostic feature, the anemia. And pallor, one cause of the pallor is the anemia. And but pallor, there are so many causes of the pallor, because if the patient going into the shock, she is not suffering from anemia, you will see the pallor. And even she is very apprehensive, there may be, you may see the pallor. So pallor anemia, but you can write down the anemia or pallor. Lower, it is seen in the lower palpebral conjunctiva, other sides at the dorsum and tip of the tongue. So it is the lower palpebral conjunctiva. That is important. You ask the patient to elevate an eyeball about, and sunlight is not must. Better to do the sunlight. Jaundice, sunlight is must. But here is not must, but good light is very important, and it takes the lower palpebral. And jaundice, it is seen in the upper palpebral conjunctiva. And other sides, the dorsum tip of the tongue, soft palate, nail beds, palm and sole, and the skin. And demonstration of the pallor, you can see here. Ask the patient to elevate her eyeball and lower palpebral conjunctiva. And some questions may be asked about the anemia. And on information, you see the recent information in the more than 50% cases of the pregnant mother in 15 to 49 of the age are anemic. According to WHO, the anemia definition is a less than 11 gram per cent. According to that, the more than 50% mother Indian women are in the new data 2019 and 2021 report. And but majority are not the very severe or severe. Most of them are the mild anemia or moderate anemia, included in the moderate. And mild, severe, very severe, the 5 gram person always admitted the patient, and severe anemia also admit the patient. And here is the questions of the depending upon the period of gestation, whether you will give the iron tablet or whether you will give the injectable or the blood transfusion, you will have to think. But mild anemia and moderate anemia is usually treated by the oral iron tablet, 10 to 10.9 gram per cent, moderate 7 to 9.9 gram per cent. And how to diagnose the iron deficiency in the exam? This will just to say what is the hemoglobin level, what is the total RBC, what is the PCB, MCB, MCH, MCHC, and the serum ferritin level is the iron deficiency is the gold standard serum ferritin. Suppose serum ferritin is not available, so important is the red cell distribution wide. This is, it will be high in case of iron deficiency anemia, but it is also comes in the theory exam, and also in the theory exam, and also in the oral. What is the characteristic of the? This is the commonest cause of the iron deficiency. Other anemia also. What are the other causes of the anemia? And also the how to manage the iron deficiency anemia? What is the dose of the iron folic acid? And what is the according to the trimester? And peripheral blood smear in the aneurysm, the microcytosis, anisocytosis, poikilocytosis, and hyperchronia, and slight increase of the reticulocytosis. This is the peripheral blood smear. Recent investigation to diagnose the IDA, free erythrocyte protoporphyrin, serum transferrin. But don't jump on so many investigations. Just the basic thing you see. today my class is for the basic thing. We will say one basic thing is the in exam it is asked what are the iron when you will prescribe the drug of the iron routine. And previous dictum was the previous recommendation was the 100 tablet before and 100 tablet after. But now the anemia book Bharat, government of India, there is the anemia book Bharat not only in the pregnant mother and the child, also the all types of categories of the women, all categories. You will give the 180 days of the iron before, that is the during antenatal period, 180 days, that is the 6 months. 6 months. Now the 100 only, because after iron government the iron folic acid tablet is tablet from the family planning program from the very beginning of the family planning program, and India is the first to implement the family planning program 1954, and that was more strengthened after the in 1977 family welfare program, and iron folic acid is given, but still there is the mother suffer from the iron deficiency anemia. And government of India also recommended for the anti-helminthic drug. I must remember the that is the albendazole 400 after first trimester is crossed. You will give government of India recommendation for to prevent the iron deficiency anemia, iron supplementation before 180 days, after delivery 180 days, and also albendazole, routine use of the albendazole after first trimester of the pregnancy. You must remember that. And related questions like the what is the injectable iron given, in also in the oral also injectable iron given, how will you give iron sucrose or iron and other iron preparation, you must FCM like that. You will give the only the iron FCM and iron sucrose are recommended. The dextran or IM are not given due to the anaphylactic shock. The cyanosis you will see the tip of the nose, ear lobule, outer surface of the lips, cheek and chin, tips of the fingers and nose, nail beds. So these are the cells, and central tongue, inner surface of the lips. Usually the patient which are given not cyanosis, the patient suffering from the heart disease or any other critical care patient that may be suffer from the cyanosis. Jaundice is very important. Jaundice. Or is the patient bring the patient to the near the sunlight, you say, and ask the patient to downwards, so that the upper bulbar conjunctiva to look downwards, so that upper palpebral conjunctiva you can see, upper palpebral conjunctiva you can see. That this is the demonstration of the jaundice. Other sides of the under surface of the tongue and not the dorsal surface, and in the soft palate and the sole and palm and sole and the skin and the skin. And from the purpurium cases, when the baby is giving baby jaundice, you will see the skin. That is very important. Because when a baby is giving, that baby suffer from the jaundice. A newborn baby physiological jaundice suffer from the physiological jaundice. So demonstration of the jaundice, you see it is the window. As the window there is a sunlight, and always in the sunlight. Now, what is actually the how will you define jaundice? It is the more than the 2 mg% of the bilirubin. That is the suffer from the jaundice, and that may cause the yellowish tinge and also the urine ornate. The question is what is the causes of the jaundice? Very important cause. The pregnancy specific cause is very important. You tell me some pregnancy specific causes of the jaundice. One important is the acute fatty liver of pregnancy, HELLP syndrome, cholestatic jaundice, and also hyperemesis. These are the 4 pregnancies. And other common is the hepatitis. And in general, what are the causes of the jaundice? You have to say the infective cause and the obstructive infective cause, infective, obstructive, and hemolytic, and pregnancy specific cause. If the pregnancy specific cause, you can say, well, then you will ask how to differentiate all those pregnancy. There is the acute fetal labor of the pregnancy, intrahepatic pregnancy, cholestatic HELLP, but infective hepatitis is not pregnancy specific, but it is very important and the complication. So you must common or more than the other. So important thing is the what should be the serum transaminase, what is the bilirubin, and chance of coagulopathy and other feature. Acute fatty liver, bilirubin is more than the 5 always, acute fatty liver. And infective hepatitis, that may be also the more than 5. But intrahepatic cholestasis is less than 5 and helps in 2 to 4 or like that. So this is the important point. Bilirubin does not rise in case of intrahepatic cholestasis and health. Infective hepatitis, you do not know how much it can rise. Acute fatty liver more. And serum transaminase and maximum you can see is the more than the 1,000 markedly elevated infective hepatitis. And also in the health. Normally the liver enzyme rises to some extent during the pregnancy. The physiological entry. And acute part of pregnancy, there is the hepatic features and hypertension, common and hypertension. And intrahepatic cholestasis is the pruritus, and there is the increased bile acid. That investigation is the bile acid. That is very important case of intrahepatic cholestasis. If there is a jaundice, you must have to face the question of the intrahepatic. What is the problem? Problem is the unexplained fetal death. Usually the chance of fetal death occurs more than 37 weeks of pregnancy, and usually when the bile acid level is more than 40 bile acid level. And more than 50, we will be very cautious. More than 50 will be very cautious. 15 will be very cautious. It normally it usually lies below 10 the bile acid. Bile acid is the indicator of the infective intrahepatic cholestasis. And infective hepatitis, there is no hypertension usually, may be associated, but history of fever, vomiting is the infective hepatitis. So this table is very important. You will get from my book. And measurement of the BP. Blood pressure is measured either in the, that is very important. I do not know how much, another half an hour will take, because we are now in the blood pressure and also the obstetric examination. Blood pressure is measured either in the sitting posture or in semi-recumbent position at an angle of 30 degrees in relaxed attitude with a slight left lateral tilt of the body. Those figures we will get. The sitting posture you will see. And this is the woman, you see, the woman is very relaxed and calm. And before taking the blood pressure, she will not be anxious, and she will not take any decongestion, very and not accident. You talk with her, and before blood pressure, at least half an hour or 1 hour, give the rest, measurement of the blood pressure. And prerequisite that she should be calm, no strain, no anxiety, comfortable. I'm sorry, BLA double D, spelling mistake. Empty, no smoking, and no diesel congestion. And what is the position of the cup? Very important. Position of the cup. And many persons are confused whether the tube will be above or below, or doesn't matter. It is immaterial whether the tubes of the bladder are kept above or below, but it is traditional the tube is kept below. And keeping the connective tissue upwards, connecting to upward has the advantage of making antecubital fossa free. The cuff should be wrapped 2 to 10 centimeters above the elbow, and it should be applied firmly but not tightly. But regarding cuff, your examination may be finished with only the blood pressure examination, like that. For obese patient, you need a larger cuff, and for thin patient, you may need a smaller cuff. And it should be the cuff should be wrapped at least 80%. That is the bladder at 80% of the circumference. 80% of the circumference. 80% of the circumference. So that is very important. The at least you say there are three varieties of cuff: small and large and middle. So at least one cuff should be available in the middle. Otherwise, if you measure the blood pressure in the normal cuff with a obese patient, the will be increased, and the thin patient that is so abnormal. So these are the three sphygmometer which measure. And it is the mercury sphygmomanometer, calibrated annual automated blood pressure meter, and best is the mercury. But problem of the mercury sphygmometer is that it is now banned. It is now banned in the many countries, and also many states of the India, and calibrated aneroid calibrated and it needs maintenance. An automated BP machine, there is sometimes in preeclampsia patient, there may be abnormal blood pressure. You can see Mercury sphygmomanometer, although gold standard, is banned in many countries and states. Also, many states are because of the pollution controls strictures in order to prevent environmental pollution. Aneroid instruments need frequent maintenance and standardization and difficult to maintain. And oscillometers have been already accepted. They are very good. No expert person is needed. Even the technician can do, but it does not need much maintenance and training, as is general need. The only problem with that is underestimated BP in the preeclamptic mother. And aneroid instrument is actually the gold standard is the sphygmomanometer. Aneroid instrument is well acceptable, but standardization and maintenance is very important. But the pressure which is given, the coroscope 1, 2, 3, 4, 5, diastolic pressure is measured the coroscope 5 in pregnancy, not the muffling, that is the 4. Coroscope 5 is the disappearance. That is the diastolic pressure measurement in case of in pregnancy. It is now well accepted. The diastolic pressure is the coroscope 5. Now, could the obstetric examination? Obstetric examination starts from the examination of the breast and also the abdominal examination. And breast examination, you write down the breast examination of the, particularly the bilateral similarity or no. There is a flat crack, that is the depressed nipple, everted nipple, and whether there is an abnormality of the nipple. That is very important. That should be diagnosed in pregnancy. With the depressed or the everted, you will have to ask the patient to elevate it during the antenatal period by manual, or there is a instrument also examination of the babe. Any male examiner, many student must take a female attendant always for examination of the babe. Also the obstetric all examination. Now, abdominal examination consists of the inspection, palpation, and auscultation. Vaginal examination, only inspection is needed, usually not needed in case of undergraduate, but postgraduate vaginal examination, for postgraduate examination, vaginal examination may be needed in some cases, and inspection is must needed in case of antepartum hemorrhage, premature rupture of membrane and puerperium, or there is a dribbling, leaking of the vagina, or there is a bleeding and puerperium, or there is a swelling, or there is any the episiotomy or like this must. But suppose if the patient is in labor, you may be asked to for vaginal examination whether to exclude the labor for postgraduate. The knot is routinely usually not done. And now you see the examiner must see on the right side of the patient and counsel of the patient what he is going to do, and the patient before that will go to the toilet for evacuation of the bladder, and he will take the permission and keep one female attendant and expose the abdomen after permission, and thigh flex and knee flex, and then you will do the examination. So preparatory procedure that a prerequisites are: ask the patient to evacuate her bladder, always keep one female attendant, stand on the right side of the patient, and explain the patient what are you going to do. Make dorsal position, thighs and knees both partially flexed. Abdomen is exposed fully and other parts are covered well. So if you tell all this point very quickly, examiner will know, you know the how to palpate. These points are very important. And inspection, palpation, and auscultation. Inspection, what is the inspecting the finding? You must say the inspector. Not all the findings you tell in detail. There is striatum, there is the linea nigra or a striatum, and linea nigra like this. There is a striatum. But you describe describe the umbilical how it is. If the umbilical is almost flat, and also the condition of the skin, and also there is the scar mark. If there is a scar mark, previous scar mark, surgical gallbladder or appendix or CN system scar mark, and describe this first. What is looking like? It is the, you will have said it is the almost spherical, uniformly enlarged abdomen, almost spherical. Term uterus term abdomen is usually the physical. Or in case of multiple pregnancy, the undue enlargement. And this is similar, but sometimes there may be maybe not similar, like in case of fibroid uterus, or there is ovarian tumor. But you described it is uniformly enlarged and the spherical abdomen, and and the of the condition of the skin, and also any pathology is there, also the scar mark, and also the suprapubic area, whether it is elevated or not, convex or not. Convex is usually occipito anterior, are not engaged. There will be the convex in the suprapubic area. Now palpation is very important. Palpation is very important. What you will see? Palpation, the height of the fundus you will see, symphysiofundal height, abdominal circumference, and foregrips. These are the, and also additionally you will see, assess the size of the baby, also the liquor with the excess or not. A clinical assess. It is assessed mainly by the ultrasonography. And height of the fundus. You will see both by hands, and also the symphysiofundal height with the measuring tape. And at that time, for measuring the height of the fundus, you ask the patient to extend our thigh, so that will be really good result. You just see, and what are the inferences? You see the lie, presentation, engagement, attitude, size of the baby, amniotic. Lie means, what do you mean? This question is asked. What do you mean by lie? Lie means it is the relation of the fetal spine with the maternal spine, that is longitudinal axis of the fetus with the maternal spine, that is lie. Presentation in the which part in the lower uterine segment, that is the presentation. Presentation may be cephalic, presentation may be podalic, presentation may be shoulder. And presenting part means the precise part of the presentation that comes into the internal os. That comes near the internal os, besides of there comes in relation of the internal. That is can only be diagnosed very well PV examination in onset of labor. But you can assess also particularly indirectly. How I am telling you. Engagement, whether the engagement or not, how will you engage? Engagement definition, how will you define engagement? Define engagement as there is a vertex or cephalic is the commonest presentation. So when the maximum biparietal diameter passes through the pelvic brim, that is called the engagement. Passes through the pelvic brim, that is called engagement. And engagement may be done by the grip, that is the Leopold III and Leopold IV, and also by fifth method, particularly in the patient is the labor. When the 2/5 palpable, 1/5 palpable, or 0/5 palpable, 1/5 palpable, or 0/5 palpable, definitely there is a engaged, and 2/5 palpable is going to be engaged. And in both poles are palpable in case of grip, pelvic grip. And it can be also assessed by the vaginal examination, relation of the lowermost bony point with the ischial spine. This is the length of the wall of the pelvis is the 5 centimeter from the pelvic beam to the ischial spine, but completely flexed vertex, the bipolar diameter distance from the lower pole is the 3 to 4 centimeter. So if it is the lower pole non-capped and non so molded head, lower pole comes to the ischial spine level, you can assume there is engagement. And attitude is the different parts of the fetus. Then the deflexed attitude, common is the flexed attitude, deflexed attitude, extended extension attitude, different form. And size of the baby is the clinical assessment mostly done by the ultrasonography, and amniotic fluid index ultrasonography. But clinically you also assess the whether the liquor is excess or liquor is average. And when you palpate, you must remember during Braxton X contraction, you don't try to palpate. If suppose you are palpating, you will see there is the irritation. There will be irritation of the uterus. Also, there will be contraction. You will not be able to palpate. even the auscultation of the body. You wait, the vaccination passes off, then you will palpate. And you will palpate, will not like this, not like the finger, but with the smooth palm and the palmar surface of the head. It's like this, not like this, not like this, but smooth. So the patient will not feel the pain, not feel the pain. You gentle palpation. Why gentle palpation? You see the height of the fundus before measuring the height of the fundus. See, he is on the right side of the patient, right side of the patient, height of the fundus. You make the uterus centralized. You make the uterus centralized. Make the uterus centralized, and from the center part is the height of the fundus. And usually the height of the fundus is at the level of the umbilicus 24 weeks, then 28 weeks, then 32 weeks. 30 this is the 32 weeks and 36 weeks, and again during pregnancy, during term 43 weeks, it will come down to 32 weeks. Why? The shape is changed, head is engaged, lighter becomes. So the shape is from pyramidal shape. Normally in before term it is the pyramidal, and after term or after their term is the date of delivery is almost spherical. Sometimes it may be cylindrical. So this is 28 weeks. This is 30. This is 28 weeks. 24 weeks into 8 weeks. This is 32 weeks, 36 weeks, and this is again 40 weeks. That is the term. So you measure clinically. It's clinically by the finger with the under border of the finger. You palpate over the fetal head after centralization. And height of the fundus can also be seen by the simple supine height. You always centralize the uterus, and the end part of the tape you will keep over the simple pubis end part. Other and hypophysis pubis, you then measure. If there is a deviation of the uterus, you ask your assistant to make it centralized, and then measurement of the simple fundal height. And this is the abdominal circumference. Usually it is the lower border of the umbilicus. In any book it is written on the over the umbilicus, but it is usually in the lower border of the umbilicus. You keep with the tape. What is the importance of this? Importance of this is that after 20 weeks of pregnancy, in every week there is a 1 centimeter increase the fundal height, simple fundal height. And it is after 28 weeks of pregnancy, there is a 1 inch. 28 weeks is a 28 to 30 weeks. There is a at 30 weeks the measurement is the 30 inches, and 1 inch every inch is the 40 inches, 40 weeks. So this is the gross calculation. But you can whether there is a polyhydramnios or multiple pregnancy. These are the abdominal 4 grips. Now this is very important. First Leopold, second Leopold, third Leopold, and fourth Leopold. I suggest you to follow this here. First Leopold, second Leopold. That is the first pelvic grip. That is the polyp grip. And previously it was said actually the second pelvic grip. And second pelvic grip, the fourth of the Leopold. Now first pelvic grip, you see fundal grip. Fundal grip, you see fundal grip. You see. I have said you don't buy like this, but your upper part of the fundus on 2 sides with the palmar surface smoothly and gently, and you try to see whether it is a hard globular or it is a soft broad. It is usually soft broad, but vertex presentation or cephalic presentation usually soft flat podalic end here. This pelvic. This is the first pelvic grip. And sometimes if there is a lichar more, and in case of breech presentation, and you get the globular and there is a ballotable, the head may be ballotable sometimes also. If there is a breech presentation or the podalic end here, breech presentation only incidence is 3 to 3.5% only. Now, mostly you will get the cephalic presentation. Now lateral grip with the palm. You keep your hand on right side. All the grips are facing toward the mother faces except the fourth Leopold. You see, except the fourth Leopold, You see the lateral grip or the second Leopold, you keep your hand on two sides. Keep your hand on two sides of the abdomen, the uterus, and laterally and more anteriorly, and fix and give pressure one hand and then palpate other, and this pressure other hand and palpate other. If you try to palpate both, you will not get what is actual. And if there is a, in case of spine, there are spine. What is the findings of the spine? Spine will be the convex, and there will be the hard. There is convex and hard, and rigid and smooth. That is the spine. Suppose the spine is on that side, that will be convex, hard, and smooth. And here the knob like pressure. Suppose you are not getting in this method, sometimes what will you do? You give left hand over the funda, and if he is over the fetal head, then the spine will be more bent, and you will be able to the spine which side, or this side or this side. So that is the lateral grip. This is very important. So lateral grip, but on the side of the spine, the occiput lies. Occiput lies on the side of the spine, and sinciput lies on the, and in where there is a knob structure. Knob structure, knob-like structure. That is the knob structure. That is the important which side. In case of left occipital position, the spine usually lie left side, and the spine umbilical line will get the fetal heart side. So you will also assess the where the fetal heart you may get either like this. And the first Leopold, and the first pelvic grip, that is the third Leopold. You keep your hand like this. That is the thumb, another phone finger, and this phone finger you go to the symphysis pubis joint, and try to get below the presenting part, below the presenting part. And in case of head, you will be able to get if it is not engaged, there will be into the hard globular head into there. It sells also the obstetrician grip, because obstetrician has no time. You will just see the like this, and you will determine whether the head or the podalic, the head or the podalic head. But because the another grip, that is the fourth Leopold, will have to like this. You see the fourth Leopold like this. Second pelvic grip or fourth Leopold will be. You keep your the ulnar border. You under the parallel to the inguinal lemur on both sides of the midline. Both sides of the midline you go. Keep your ulnar border. Parallel to the midline. Parallel to the both sides of the midline, and parallel each hand parallel to the respective inguinal ligament, and try to go below and backward, downwards and backwards of the presenting part. You will see what you will say, what will your inference is same like the podalic grip. What is the presentation, whether it is engaged or not, and what is the attitude. So three inferences you give from the fourth Leopold, also the three Leopold. What is the presentation? If the hard head is felt, that is the cephalic presentation, hard and globular, and whether it is engaged or not. If the both poles can be palpable and mobile, and finger can be insinuated, that the head is not engaged. And how the attitude is the relation with the sinciput and occiput. Sinciput or the, suppose there is a sinciput, there is a occiput, and then suppose this is the occiput on left side, and there is a sinciput on that side. So you have determined the spine on that side. So spine of that side means the occiput is there, and there is a knob-like structure, the sinciput is there. You see the level of the sinciput occiput. If the same level means the deflex. If the sinciput is above, occiput is below, then the flexed, and the sinciput below, occiput above, that is the actually extended. So you can determine the presentation and presenting part, and also the attitude, and also the engagement. Presenting part I am saying how. Presenting part I am saying, presenting part is that precise part of the presentation. Means presentation is actually cephalic, but presenting part is the occiput, is the brow, and also the face. But it is can only be examined by the vaginal examination or vaginal examination. But if it is a deflex, that is the occiput. If it is flex, that is also occiput. If it is extended, that is the face or bow. So that is the indirect method, and that is mainly needed during actually the labor and just before labor for assessment of the pelvis. Because once the head is engaged before the onset of labor, you are sure that there is no CPD, cephalopelvic deportation. The method of cephalopelvic deportation is the you know the bimanual method. Bimanual, that is the bimanual method. You try to molar Mundokar method. Molar Mundokar method, you try to insinuate the fetal head and keep your thumb and index finger, a thumb in front and index finger inside the vagina. And if it goes at the level of the ischial spine, and if the lower pole comes to the ischial spine, the head is there is no CPD. You keep your thumb just above the symphysis. This is the symphysis. If the head pushes it, there is a definite disproportion. Just touches it, there is a borderline disproportion. And if it goes, no disproportion. That is the Muller Mundokar method to see the cephalopelvic disproportion. Pelvic assessment is two types. One is to see the CPD, another is the inside. I am not going into the pelvic assessment. There will be another class how we will assess the pelvis, the different pelvis, and what is the capacity like. But these are the two parts, pelvic assessment, and this is the CPD method. And now the auscultation is very important part, very important. And don't declare you do not get the fetal ultrasound. There is the intrauterine fetal death. You may not get, because intrauterine fetal death is usually patient will see. Patient will may say, but don't declare before going into the intrauterine. But you are not getting fetal ultrasound. Probably that maybe you are not able to get. You are not able to get. Some precaution you will have to take. So if usually in case of occipito-posterior, the fetal ultrasound is audible on the right or left spinal umbilical line, right or left spinal umbilical line, and on the side of the spine, if the spine is in there, you put it here. You can go in the bale or diaphragm. Bale is better some cases. I personally like the bale. And during examination, suppose the examiner is asking you to show the fetal ultrasound, all the prerequisite preparative procedure you've done for for abdominal examination. If you jump to this, you tell that I will do the like evacuated bladder, patient is I'll take the permission, expose and female attendant, high place, knee place, like that, and put there. And left hand, you can see the left hand is the radial force. You compare the radial, because if there are the maternal pulse you will get also, the uterine artery pulse, also the aorta pulse sometimes gets in the stethoscope and may be confused. In case of intrauterine fetal death, the thin patient, the sound is failed and FH is plus, and there is a medical legal case which is plus. You are saying previously there is a first visit there the FH is plus. I am now saying, so you have neglected like that. So you must keep your hand in the radial artery. Whether it is coincident, radial usually maternal pulse is 70 to 80. Fetal heart rate is almost double, and it must not coincide. You see, what will you see? Whether the fetal heart sound present or not. What is the rate? What is the rate? It is regular or not. It is regular. So three things: present, rate, and it is regular or not. So this is about the fetal heart sound. It you must confirm with the ultrasound if there is a problem. And sometimes you may not get. So what will you do? Suppose you have your hand is there, you are not getting the fetal sound. So keep your left hand over that side, and pressure on the opposite side. So the fetal heart will come near the bale of diaphragm. That is visible. And sometimes in the occipito-posterior, it goes to the flank. So you must remember, it goes to the flank. For not getting, you go to the flank. You may be able to get at the flank occipital posterior, and breech, in case of breech, it will be little higher. The frank breech is like the occipital anterior vertex. So this is all about the examination. All over the examination. And investigation supplied are required. Blood hemoglobin, that is the complete blood count. Previously, it would show the only hemoglobin is sufficient. But now the WHO says to do the complete blood count. If it is not available in the facility, we do only the blood bedside people. That is also the sufficient. And ABO grouping and RH factor you must do. Routine VDRL you do. Urine examination for protein, sugar, and pus cells. And blood glucose estimations. In India, universal is suggested at first antenatal visit due to high blood glucose. You must do. And there is if you are asked what are the blood sugar examination in India, universal screening in first time and the first visit, universal screening with the one test or by the two test. One test method, that is the giving the 100 sucrose glucose, and you to the one test method. So this is the principle of the blood glucose estimation. If it is negative now, then you will have to do this in the second trimester, universal for India. There are some difference of the opinion of the different, like the SUG and Indian guideline and Indian Association of other international association, diabetic association. But for India, a first trimester and universal screening, that is the important for the GT. You read this from book, very well written. Now HIV testing, PPDCT, hepatitis B surface antigen, cervical smear for Papaniculostil. It is not routinely done, it should be done. As tool for routine examination, particularly the many of the rural people goes in the there is no slipper or like that. And USG for pitoplacental profile and amniotic fluid index the TARP. And other investigations, you say the rubella antibody to detect the rubella immunity. In fact, any patient suffering from infertility, if you come, always do the rubella antibody. For rubella antibody, if it is positive, then okay. If it is negative, you give immunizing. And rubella cannot be given during the pregnancy. If the mother suffers from the rubella during the pregnancy, the baby may suffer from the congenital anorexia. And thalassemia screening is testing. It is though not universal screening, but it should be done thalassemia. And also the thyroid screening, TSH, T3, T4. That this is not routinely by the Indian government guideline, but it should be done. And combined test, you know, all of you know, this is also the routine. One is the combined test and another the anomaly scan, the ultrasound. Combined and ultrasound biochemical USG at 11 to 13 weeks, screening test for aneuploidy Down syndrome. So these are also done. This is now routine combined test and the anomaly scan. Anomaly scan and combined test in the antenatal period routinely you do it. Otherwise, if there is a congenital anomaly in the late pregnancy, the patient will be very aggrieved and they will go for there are many cases sue against the doctor. The anomaly, why of the advice for anomaly scan, but you must do it. So these investigations are done, and majority of the investigations are done in the first visit, advised, and others are successively. But routine 28 weeks and 36 weeks, you do the hemoglobin. You must do hemoglobin percentage. You do for the Indian government. The summary. Now come to the summary. Almost end to our topics. The summary you will. This is very important because that you will present to the your examiner. Patient's profile and complaints, and what is our LMP, what is the rigidity and period of amenorrhea, and present obstetric history and past obstetric history. Present obstetric history and past obstetric history. If there is the patient is the multigravida, not primary. Significant other history, positive and relevant negative, I have also mentioned. Important physical findings, including the vital sign. Not physical signs. It is negative. It is negative. It is negative. You know, negligent, not palpable. So not routinely said. But you say the positive point. Is the positive point. Only thing you will see whether the pulse BP you can say pulse like that, pallor the routinely said, edema nil, and the BP is there like that, or normotensive you can say. An obstetric examination finding you will see. Investigation supplied or required. Your exam may end with the investigation, different investigation, and will hotel will do. Now the example. Mrs. PR aged 28 years. Gravida 2, parity 1, living is 1, male, alive, well, and immunized. And last child was 3 years back, belonging to a low socioeconomic status and staying approximately 20 kilometers from the hospital, was admitted on auto with the complaint. So the present profile and past obstetric history and present obstetric history, I already uh, uh, is like that. With complaint of swelling of leg through OPD along with amenorrhea of thigh. So you said the complaint and along with write the amenorrhea for 30 days. Not he has admitted for 38 weeks of amenorrhea. Pregnant mother, obstetric mother, she will be admitted with obstetric. So why is he presenting now and why is he admitted? You can write down the same vaginal forceps vaginal detail, but don't only the third. And her LMP is EDD is like that, and period of amenorrhea is like that. She has received regular antenatal care in this pregnancy. And how many times you can, that patient examiner will tell how many times you say, what is the normal? You can draw your question. Examiner, the 8 checkup, usually 8 checkup, the book case previous was the 4, and nice guideline says is that are 10 checkup, but WHO now said is the 8 checkup, or what is here given, and what will you do, what immunization is done, what are the immunization is done, what the tablet will be given, iron folic acid, there is antenatal care. She has taken iron and folic acid prophylactically, tetanus toxoid or TT immunization, and she had developed hypertension from 8 months and now is controlled with labetalol 200 milligram thrice daily. Her previous pregnancy was uneventful with full-term normal delivery. She had a history of appendectomy 4 years back. Her father is hypertensive and mother is of normal healthy. Normal healthy. On general examination, and height is 4 feet and weight is at the BMI. Pallor mild, because you are clinically you are doing. And pitting edema present and pulse, BP, you may write normotensive and any other positive finding. No abnormality detected in a systemic examination based on normal. On obstetric examination, you can write also grip wise, but it's better to write like this. The height of the funda correspond with the period of amenorrhea. Single fetus is longitudinal line. Presentation is cephalic. Replaced fatigue, that is not. You can say also the grip wise. Hospital grip is but it is better to say like this. There is average amount of liquor and no painful uterine contraction because vaccine is there. No uterine contraction, you do not write, should not write. Fetal movement is present. FHS is 140 per minute. Regular, you can write in the prominent of the right spinal muscle. Investigations report, hemoglobin, blood group, hepatitis B surface antigen, hepatitis HIV, negative, PPBS, postpartum blood cell, that is the VDRL, urine for protein is present. And the screening, infection screening during pregnancy, you are saying that is the rubella is now included, infection screening, rubella, the standard international screening. So RUC findings to say like this. The provisional diagnosis, 25 years primary gravida at 32 8 years of pregnancy with preeclampsia, hypertension, PH, vertex presentation, fetal ultrasound on 40 per minute. But you must say the baby is living or fetal ultrasound. Suppose you finish it here, 32 weeks PI. Whether the baby is laid or living, that may be altered. Examiner to examiner alters what is wanted. But you do standard and you can modify what examiner you will judge the examiner. You also judge the examiner what is asking for. But this is the standard, it will be helpful to answer all the questions. So with best wishes for all of you, thank you all. If there is interactive session, you can ask any question if it is possible. Dr. Mala is there. Dr. Mala. Thank you for patient sharing. Hello. Any student can ask any question. Any student can ask any question. And then unmute yourself. Hema, Chandana, to everyone. That is cholestatic jaundice, intrahepatic cholestatic of pregnancy. Intrahepatic cholestatic. Hema, what are you asking? Hema, you unmute yourself. What is your question? Hema, are you audible?
Yes, sir. I wasn't asking a question. There, you were asking DD of jaundice, so I just typed
Oh,
the
you are
answer
answer.
there.
I have not seen
Yeah.
actually.
Yes, sir.
Intrahepatic cholestasis of the jaundice. So
Yes,
that
sir.
is very important. I think you will be able to say all the question answers. What are the causes of the jaundice specific to the pregnancy? And you will
Yes,
include
sir.
also the hyperemesis gravidae. Other
Okay,
than the
sir.
acute fatty liver of pregnancy and the HELLP syndrome, intrahepatic cholestasis, and you will put the hyperemesis gravidae also. And
Okay,
viral
sir.
hepatitis is not the pregnancy specific, but is the commonest. And you can ask any question. Have you
Yes, sir.
understood today? It is
Yes, sir.
helpful.
Yes, sir. Very much.
Hmm?
Good evening, sir. Could I please ask something?
Any question?
Sir, I
Jyoti,
wanted to ask, yes, sir, good evening, sir. Sir, I wanted to ask whether should we ask direct questions in our history of presenting illness, such as if our patient came with headache and symptoms suggestive of hypertensive disorder, should we have asked for other direct questions, such as itching all over body or to rule out liver disorder?
definitely you ask.
Okay.
You can ask the leading question to the patient. And probably she has said our attending doctor are not showing you. Right. Taking history is an art. And one important problem is particularly for the DNB student is the language problem is as important. And if you go to the south, go to the Bengal, they not always do not understand the Hindi or like that. But there is the interpreter. Interpreter will always help you.
Yes, sir. Thank you, sir. Thank you, sir.
Okay. If there is no question, Dr. I think Mala is not there. Then can I leave? It is about 1 hour 40 minutes. Thank you all. Thank you.